Good morning, everyone. Thank you so much for joining us here on Facebook. We are going to be having a special treat today, talking to two experts about the Omicron variant. Good morning, everyone. Thank you so much. Let me turn off the sound on my phone as I'm following along as we're doing this on Facebook. But we're joined today by Dr. Suzanne Judd. She's an epidemiologist at UAB, and Dr. Jody Dion, who is an infectious diseases specialist who we all are familiar with at this point in the pandemic. We are so grateful for you taking the time to share your expertise with our viewers and to answer some questions. And I want to go ahead and just open it up to give you guys an opportunity to give an opening statement. If you'd like, Dr. Dion, I know that our test positivity rate today is back up to 44% statewide, and that's just numbers that we're seeing from testing sites. So this doesn't include at-home testing kits. So can you kind of give us a gauge on what that means when we're seeing that much virus in our community right now?
Yeah, and I'm sure Dr. Judd, as an epidemiologist, will have some things to add too. What it means to me is that there's a lot of virus circulating in our communities. And when you look at the state map of Alabama on the ADPH website, it's not like there's part of our state that's affected. It's across the whole state. We know that this variant is particularly transmissible. We know the mutations compared to the Delta variant make it very easy, as much as twice as easy to spread between people. And that's why we're seeing so many people in the hospital right now. So we have about 247 patients at UAB right now who are admitted with COVID-19. And this is a peak that's similar to a peak that we had last year with Delta when the numbers were really high. So even though there are indications that this virus tends to be milder, especially in people who are vaccinated, there's still a lot of people getting very, very sick who are needing ICU level care and intubation. So still something to pay attention to. We all want COVID to be over, but until the virus is really gone from our communities, it's just not over yet.
And it's just really tough in our state to track what the meaning of the various metrics that we have. Those metrics like case positivity, they're really important when you know that everybody that's should be tested is getting tested, and that's just not happening in Alabama. We don't have as many test kits as we need for our state, given the level of circulating virus. That's why you're seeing it kind of go up and down, hovering 40, and then it goes down. Now it's back up at 44. It's really just a function of who has access to tests and who's getting tests that get reported to ADPH. Those at-home tests that people are taking, those don't get reported to ADPH. There's not a mechanism to get them in the system. So we're just systematically missing a lot of folks that are testing positive for COVID. And it makes tracking the peak, that's the number one question I get right now for the last 7 days is, are we at the peak? And I would love to say, yes, we are. But honestly, the data that I have, it's really tough to draw that conclusion because of the fact that we really seem to have plateaued. And I really think the plateau is not because the cases have plateaued. It's just that we hit the testing maximum that we can do in our state. So it's never going to see that really high peak. We just don't have enough tests to do that.
So then, Dr. Judd, tracking this virus, that makes your job more difficult since we have hit that capacity with testing. What other metrics are you starting to rely on more? Maybe is it the hospitalizations or is it deaths tragically? What are you looking at now?
I'm looking more at hospitalizations because this one does seem to be milder. So the deaths are not as, they're not as pronounced as they've been with other surges. So hospitalization is a great indicator. Interestingly, one of the best indicators are the people coming in who don't think they have COVID. We call them incidental hospitalizations. They're there for a car accident or a heart attack, and they happen to test positive for COVID too. In epidemiology, we call that the asymptomatic positivity rate, and that really gives us a feel for what might be circulating. We have other populations that we can study, like athletes. Athletes in our state are required to test even when they don't have symptoms, so we can track their positivity rate. And then lastly, we have several employers like UAB that are mandatory reporters, meaning that the workplace requires their employees to let them know if they test positive. So I've also been tracking the rates at UAB among our employees and comparing that to the employees that are releasing their information publicly. Some of the airlines are releasing their data, so it makes it really easy to see what's happening there. And all of those things kind of put together a picture that does make it look like we are starting to peak and come back down, particularly in Jefferson County. Omicron hit Jefferson County first, which is very consistent with what it did throughout the country. It seems to hit the more urban areas, the areas where people live closer together, a little bit more rapidly and move through the population more quickly. So there are positive indicators right now in Jefferson County, but again, we just kind of have to wait another week to see if the trend holds.
Dr. Dion, a couple of weeks ago, we talked to Dr. Nafziger about the incidental infections, like Dr. Judd was just pointing out. And she said at that point, it was about 40% of patients. And this was when Omicron was really starting to impact our area. Would you say that that's similar now, or are you seeing more people coming in truly because they're infected with COVID and they need treatment, or are you seeing a lot more of the incidentals?
I don't have the current number. Dr. Judd may have the current number for UAB system. I think that it's very helpful to do screening on admission, because in terms of thinking about where you're going to put patients in the hospital, and as we see them in infectious disease, they may come in asymptomatic, but develop symptoms 2 to 3 days later. And if we know they have COVID already, we're watching them very closely, we can manage them better. But as far as your question with the comparison, I can't speak to that. I'm not sure.
Okay.
It has ranged. I haven't seen it this week, but 40% to 50% is about right, but it varies.
Okay. Going back to how patients are faring with this, Dr. Dion, are you still seeing success in some of the treatments that you were able to use with Delta and with the original strain of COVID, or are you guys having to change how you're treating patients with Omicron?
Yeah, so I would say it's complicated, and it's a good problem to have. We actually have many more options than we did when we first started. You know, we have very effective vaccines and we have treatments that really work. The monoclonal antibodies that we've been relying on to keep people out of the hospital, this is the infusion given early when symptoms begin to prevent someone from being hospitalized. Some of those monoclonal antibodies do not work for Omicron. They were tailored for Delta, created for the first virus, really. And with these, 30 to 40 mutations on the spike protein, they're no longer effective. So unfortunately, you're right. Some of the options we were using before are no longer as effective. Fortunately, we do still have a monoclonal antibody therapy that is effective. And even better, we have antiviral therapy, which can be given at home as a pill regimen for just 5 days. The one that's really the best, the most effective is Paxlovid. And this regimen is about 80 to 90% effective when given to people early on within the first 5 days of symptom onset, of keeping them out of the hospital and keeping them from dying. So that does appear to work very well, even for the Omicron variant. The data is early. This just got EUA approval at the end of December. So we'll learn more about it in the coming months to years. This antiviral looks like it will work even as this virus continues to mutate because of the target that it uses. So this is a very, very exciting advance. The issue right now is, for all the patients I'm seeing with COVID in our clinic, we're trying to get our hands on Paxlovid, and I can for some of them, but then the statewide supply runs out pretty quickly. So it's a supply issue right now with this really effective drug. And the same thing for the effective monoclonal that we have. Yeah.
Have you guys been able to get some more? That's called sotrovimab, correct? Have you?
Yes. We're getting it, but it's burning through almost immediately when it comes to the state. We have a long list of people who are shortlisted to get it based on their priority conditions, their underlying conditions, pregnant women and people with medical comorbidities. So we get it, but as soon as we get it, the supply doesn't last very long.
One thing too, and when we're talking about Delta versus Omicron, and if you obviously are getting protection from the vaccine, and we saw the major surge with Delta, and a lot of the patients hospitalized did not have the vaccine. The patients now, is that still the same trend, or is the vaccine offering protection against Omicron and keeping people out of the hospital?
Dr. Judd probably has some things to add. I can tell you that from the population level, the studies are showing that the vaccine, especially for people who are boosted, is effective against Omicron variant. So this is still the vaccine that was created for the earlier circulating virus, and it is keeping people out of the hospital well. The efficacy for hospitalization has dropped from 95% to more like 80%. And the efficacy with Omicron for infection is more like 40 to 50%. So it's not as good as it was. But remember, a vaccine that keeps you out of the hospital, that keeps you from dying, is working very well. I don't want the message to get muddled that the vaccine is a poor vaccine. It's great. Keeping you out of the hospital and keeping the virus in your nose, if you're asymptomatic, is still a win as far as the vaccine goes. The latest numbers I can say at UAB, of the patients who were admitted, 71% are unvaccinated. So we're still seeing a large majority of people who are admitted who have not had a single vaccine. Of the people who are vaccinated, remember, some people don't respond to the vaccine very well. Take care of patients who are immunocompromised. So some of them may have been vaccinated but didn't respond because they have cancer or on chemotherapy or have other conditions. So that's part of the reason we've been saying since day one to get vaccinated, right? Is to protect those people who can't be protected with vaccination. In
Yeah,
some hospitals, I know
exactly.
hospitals in Chicago, 100% of their inpatients are unvaccinated. So I think it varies by city.
Yeah, that's exactly right. And it's CDC is doing a great job tracking it now, that posting it each week to see how it updates. And it's still people that are in that, you're 17 times more likely to be unvaccinated if you're in the hospital than if you're vaccinated. And again, that vaccination, it's really just to keep you from getting super sick. There are certain viruses, and as epidemiologists, these are great, like measles, where we can vaccinate you. And if 90% of the population gets vaccinated, we know nobody's going to get measles. Coronavirus has never been that type of virus. We hoped it would be, because there was a particular coronavirus called SARS 20 years ago in China, where it was a much more severe version of coronavirus than the one we're currently experiencing. But that one seemed to create lasting immunity. With this current version of coronavirus, it seems like it's going to be a normal coronavirus, which means you're looking at 6 months of immunity after you get a vaccine or you've had an infection. So that's probably going to require some regular vaccination to make sure that we keep our immune levels high enough to keep us out of the hospital. And again, we're familiar with diseases like that in epidemiology. There are lots of diseases that are that way. Influenza is a good example of one. In childhood, there are other viruses. Rotavirus is one that we regularly immunize children for to get that immunity up to where it needs to be. And this is what this one's going to be.
I want to take a moment to just remind people who are watching on Facebook to share their questions in the chat, because I'm monitoring them just to see if there's anything that people are asking or if they have questions about. I saw one question earlier that was about immunity. Are people able to get immunity from, if you had the first COVID, if you had the Delta, are people immune from Omicron? And I think we're kind of seeing that no, people are still able to get Omicron. But can you kind of explain how that works, how you're able to get it even if you had the other variants?
Sure. Viruses they're interesting. There are two factors when you talk about immunity. One is the virus can change. The virus can change itself in a way that your immune system doesn't recognize it as efficiently. And a second way is that your immune system builds up its defenses and it gets them really high when it's fighting it. And after the threat is gone, your immune system retracts back to a lower state, which is a good thing. You don't want your immune system ramped up constantly, because then you run the risk that your body will attack itself. So these are very normal processes in the human body. And a lot of viruses or bacteria behave in this way, where you can get infected, you have some immunity, and then that immunity wanes and you can be reinfected. It's a very common thing. Because of the fact that COVID-19 was compared to measles early on, that was the one that everyone kept talking about. I think that people hoped it was going to be like measles, and we're going to be on this 10-year booster campaign and be fine. But again, there are lots of viruses that behave this way, where you can be infected and then be reinfected. Delta to Omicron, we don't know what that timing is. Is it 6 months? Is it a year? Influenza is cyclic. It tends to happen in the winter. So I think a lot of folks are trying to compare it to influenza and say that's what's going to happen. But the reality is, we don't know with this one what the immunity cycle is going to be. We're just learning it. And most coronaviruses, unfortunately, are more on 6-month cycles with your immune system rather than an annual cycle. So we're just going to have to wait and see what happens. But definitely you can be reinfected. It's possible to be reinfected as quickly as 2 to 3 months based on the data we have. And the real challenge with infection, with a vaccine, we can control the dose you get. We know exactly how much you're given, so we know how much your immune system responds. When you get infected, we have no idea what dose of the virus you have, because that would be silly. You can't measure the dose of a virus. But the dose that you receive determines how effectively your immune system responds. So if you get just a teeny tiny dose, you might not build a huge immune response to that virus. And it may take time of teeny tiny exposures for you to get that immunity up. And that's what makes it tricky when people say, well, I was infected. Well, yeah, but we don't know how badly you were infected. So it's just tricky.
And Dr. Judd, I'm what you were just talking about is one of the questions that we received from Jared, is how well does natural immunity protect against hospitalizations? And you just touched on that. And one thing I've heard Dr. Karen Landers with ADPH say before is not everyone gets the same immune protection. So it really is hard to give an answer to that type of question. It just varies by person.
That's right. That's right. And Jared, the reality is ethically, I can't infect you with COVID. Turns out there are certain things in science we can't do. We can't randomize you to be infected with COVID. So there's just no way for us to scientifically study what a COVID infection does in terms of immune response. We can look at you after the fact. We can say, okay, this person was infected, what happened? But to really understand the science of it, we would have to control the dose, and that you can't do that. We can't infect people. So.
Dr. Dion, a question for you. How many of the hospitalized patients, this is from Rachel, are suffering from the Delta variant right now? Is the Delta variant still circulating in our area?
So I know that as of December, a majority of the viruses that we were sequencing at UAB coming from around the state, 99% of them were Omicron. So we've had that rapid switch. Even when you looked at the data from South Africa, they had really 100% Delta variant. And within 2 weeks, it was 100% Omicron variant. That's the evidence of transmissibility of this virus. It doesn't take a long time to take over. It really takes over quickly once it takes hold. So I did see around Alabama, there were some others reporting that they're still seeing Delta variant in their hospitalized patients. I think it's still there, but I think it's going to become a vanishingly small fraction of what we see.
So correct me if I'm wrong here, the way that it works when one variant becomes the dominant variant, obviously it's forcing the other variant out. And what happens, how is a new variant created? I'm sorry, I got to totally start over. When you're saying that there's multiple variants that are possible to come after Omicron, how does that happen? Can you explain that for people? Because that's kind of a new introduction to variants is really confusing to people.
Yeah, so think about the virus wanting to persist and infect people. That's the virus's purpose, right? In order to do that, as it's circulating in a population, it's going to hit certain pressures. And those pressures are people who already have immunity. It can't infect someone who's already had, let's say, the same coronavirus because they have good B cells and good T cells, both of which are key to a good immune response. The virus is then going to be selected if it's able to evade that immune response. So that puts pressure from an evolutionary perspective on the virus that's able to change its surface proteins so that it can get by those antibodies that were created for the first variant. This is often seen in someone who's immunocompromised. Imagine someone who's getting cancer chemotherapy, who is unable to clear the virus from their nose and from their respiratory tract. There have been people that have had coronavirus continually detected with cell culture for 250 days. That is giving the virus an incredible amount of time to change and mutate and turn into a variant or a new type of virus that is able to evade the immune response that other people may have. So it's not as if Delta all of a sudden becomes non-infectious. It's still a bad virus, but many people have now been exposed to Delta. Many people have either been vaccinated against something that works for Delta or have had Delta infection. So they have those antibodies, and that helps create that pressure for these new variants to emerge. Once that new variant emerges, even if it's just in one person, if it's very easily spread to other people, then you can get this rapid explosive type of spread. Airports between cities, that's what we've seen around the world with these variants. So what we're saying in terms of response is we don't know what the next variant will be. This is something Dr. Judd just mentioned earlier in this hour. We are worried that the next variant could be different and could be worse. Certainly it's going to be mutated to escape the immune response that we all have right now. That's what viruses do.
Is it true though that the variants become less severe?
This is a hotly debated topic. And I would say I've seen some people argue that over time, in general, the mutations are such that you're evading the immune response to be more transmissible, and that comes at the cost of fitness. There tends to be less severe illness. I've also heard virologists very eloquently explain that because you can't predict what the next set of 6 or 10 or 30 mutations will be, we could still end up with a more virulent and more infectious variant the next time around. So it's not preordained that we're going to go toward consistently milder versions of the virus. But I'm interested to see what Dr. Judd thinks.
Yeah, the problem too is it's in a terminology and the way that we describe things in science. There's this version of coronavirus, which is SARS-CoV-2 when we talk about it. There's nothing to prevent the coronavirus virus from turning into SARS-CoV-3, which is now substantially different than SARS-CoV-2, enough so that it needs its own name. And technically, we would not consider that a variant of SARS-CoV-2, but we're splitting scientific hairs now, and the public doesn't care. What they care about is there the potential for really deadly viruses to come back? And the answer to that is yes. Any virus can mutate at any point in time and become more severe. But this one specific virus is more likely to mutate itself into a more benign virus. But again, it could also jump into an animal and then become something totally different. So that's what we track as epidemiologists. That's one of the reasons why it's really important to monitor all of the viruses, including influenza, including coronavirus, including RSV, and all the viruses, to see what's going on and how they're changing.
One thing, Dr. Judd, I want to get your view on, and I know you kind of talked about this in your media briefing yesterday. Earlier this week, Dr. Fauci was asked if Omicron could signal the end of the pandemic and then transition to an endemic. And then when there are flare-ups, you have the epidemic. And all of that really kind of means it would be kind of like a flu season, but not like the flu. I want to be clear in saying COVID is not the flu. But a season like that, is that possible with Omicron? Dr. Fauci said that's the hope. What is your take on that?
I agree with him completely. I think that's the evidence now with three big surges in our state. It's evident that this is not one that surges and goes away. So this is one that we have to figure out how to live with, which that's what endemic means. I think people might think endemic means that it's not a severe virus. That's not true. There are places where typhoid is endemic, and typhoid is a very, very serious illness. So endemic just means it's always there, and there's always the potential for an epidemic spike. So the epidemiologists have to monitor it a little bit more carefully, but it means that we live with it, and that the goal is no longer to eradicate it. It's to figure out, how does society live with this virus that we're not going to be able to make go away forever. And the big things on that will be, number one, if this virus mutates itself into a version that's less severe, fewer people winding up in the hospital, keeping the resources, the hospital resources where they need to be to manage all the other things the hospital has to do, then we'll probably say, okay, we can live with it. The other thing would be just watching these regular surges and how it's mutating. Those are the things that we'll be watching to see how we live with an endemic virus. But behavior may change forever. I keep joking, and I'll bring it up again. I think now we really need to be talking to the health behavior, the psychologists, to ask about what is the lasting behavior change that's going to come from this. Will we now go through these cycles of wearing masks and taking them off again? And how will we define that? How will we communicate it to people? How will we communicate that it's important to get a new vaccine? Let's say that we do monitor the variants and we find out with something like Omicron, it's going to be important to change vaccine composition. How is that communicated to the public so that they understand and know it's time to pursue a new vaccine? It's really time for us to start bringing in the health behavior folks to answer some of those questions.
Dr. Dion, I have a question here from a person named Shirley. She says, how protected is an individual if they only had the first Moderna shot and can't get the other shot until February? They're asking for a friend.
Assuming the person's asking right now, it's January, they can't get the shot for another month. So we know that the first vaccine does give you some protection. When you look at the amount of protection, it's about 50% of people that had responded after the first dose of these mRNA vaccines, and then up to 90% with the second dose. It's hard to predict at an individual level for your friend, because I don't know what her immune system is, and I don't know as many details of what her exposure level is. I do think that anytime you're unvaccinated or incompletely vaccinated, you need to be careful. You need to do what you can, which is everything what people have been doing up until this point, to prevent yourself from being exposed to someone who could be sick. We have seen many, many cases of asymptomatic transmission where someone doesn't know they're carrying the virus in their nose and they transmit it to their loved ones and their family members without realizing it. So, it's only a few weeks now until February. I would say continue to be cautious and social distance until then. Get your second dose, and then after 2 weeks, your antibody level should be good. Put your appointment on your books for your booster 5 months after that.
Another question for you. This is from Diane. She says she has COVID and she's had She is at high risk because she has lupus. Her doctors say there are no infusions, monoclonal infusions to be found. She's been vaccinated and still got COVID. Why is there a shortage of the infusions? And I know you kind of touched on this earlier, but if you could just go over that for Diane.
Yeah, so I mean, Diane, I totally understand what you're saying, and it's frustrating for everybody because we do have these options, but it's hard to put our hands on it. There's a lot of pressure on these companies to make a large supply and make it available for everyone in the country who needs it and make it free of charge. So it is coming. I hear these Paxlovid are being made millions and millions of doses. I think even that we're going to need more. I think the answer for you is that we need a better system so that when we, through clinical trials, identify effective agents, there's a way to upscale production really rapidly. And that may be beyond what the company itself can do, probably requires additional financial support to be able to upscale at a large amount to get it to everyone who's in the same boat that you are. If you were, I'm sure you're in close communication with your doctor, you should monitor your oxygen saturation closely. You should monitor your symptoms. And if you're not feeling well or you're not able to catch your breath well, obviously call your doctor as soon as possible. Chances are good because you were vaccinated that you will do okay. I hope that you do.
And one more question for you, kind of touched on this a little bit more, but it's more specific about the antiviral pills. From Tammy, she says, do you know how many people have received the medication to treat COVID? I know in our state, we initially received about 800 doses of Paxlovid, and then 30,000 we were supposed to get of the Merck, but that one is not as recommended, like you mentioned earlier, as the Paxlovid. But her question is, does data exist regarding drug interactions with the medication?
Yeah, so it's particularly important for the Paxlovid. So the Paxlovid is a combination medication. Nirmatrelvir is the first name, and the second is ritonavir, which is one of the drugs we use to treat our patients with HIV. This does interact with some seizure medications, interacts with some cardiac medications, it interacts with some of the medications we use to treat infections. So have your doctor be aware of that and have your doctor check those. I would say for the most part, people can take it well because it interacts with medicines that not many people are on. This is a 5-day regimen. You're on it for a month or two. For that short period of time, the interactions can be well managed. The reason that we recommend Paxlovid higher than the molnupiravir is because of the efficacy. The efficacy of Paxlovid is 80 to 90%, and the molnupiravir efficacy is more like 30 to 40% at keeping people out of the hospital. So if I have those two options, I want to give my patient the best option they can have, and that's Paxlovid. A few caveats around this use: it cannot be used in women who are pregnant, and women who are of reproductive age should make sure that they're using contraception while they're on therapy and for several days after therapy. For men who are who could potentially be interested in fathering a child or are reproductive age, the recommendation is to use contraception for 3 months after use. And this is because the way the drug works is by inserting mutations into the virus itself. And we don't know yet if there's a potential for mutagenesis at the human level within our cells. The initial studies say no, but more studies need to be done to be sure. So those are all the specific things you want to think about based on your life and the situation you're in right now. The concerns are not the same for molnupiravir. So if you're a pregnant woman, we're going to be offering you molnupiravir or the monoclonal antibody therapy and not the Paxlovid.
And one more question, and then Dr. Judd, I want to talk to you about something else specific. Kanisha is asking how long, and this, the CDC just changed all the quarantine guidance over the past couple of weeks. How long do children that cannot get the vaccine need to be quarantined?
So I think that the children are now in line with the adults, that the recommendation is now 5 days for quarantine. Remember, quarantine is after exposure, not for people with a positive test. The recommendation is after those 5 days, they should still be tested. Obviously, if they develop symptoms within those 5 days, they should also be tested. They can then go back to school at the end of 5 days with a negative test, but they still need to wear a well-fitting mask because of the potential within the next 5 days for developing infection. It does change quickly. So that's the latest I've heard. So I hope that's the current.
Yeah, it has. And obviously that changes based on science that comes in and how they're seeing how the virus spreads and how, the times when you are infected, how long you're infectious, and how long you can spread. And as they're getting more information, and that's why these recommendations are changing.
Morgan, you've been doing lots of COVID, or you get on the data definitely down. Yeah, I mean, CDC did these new studies showing that the incubation period for Omicron is about 3 days. So that means the time between when you're exposed and when you're likely to have that sore throat, headache, malaise feeling is about 72 hours. We know from many studies now that the virus is highest right before you have any symptoms. So even when you're still feeling well, through the first 2 to 3 days after your symptoms start.
Dr. Judd, one thing we hear a lot from viewers, questions about what's going on in schools right now. And I know that there are some Birmingham City schools that are a part of the testing program, but are you seeing a lot of spread in schools? And then do you have a way to compare that to schools that require mandatory masking?
Yes, that's a great question. CDC has published some really great studies over the last 2 years looking at spread in schools, and they've identified that schools that have masking policies have a much lower rate of COVID in the classroom than schools that don't require masks. The highest benefit has been up to 80% reduction in case transmission, and the lowest is somewhere around 50%. Which is great. Honestly, again, this does not assume that the kid wears the mask correctly, although we much prefer them to wear it correctly. All it says is that if there's a policy in place, we know that the transmission goes down. What we're seeing right now with Omicron, those data haven't been published yet. It'll be really interesting as those data start to come out. You know, number one, because masking is not as universal as it once was. So it'll be a little bit more challenging to look at that data. Like you mentioned, the School of Public Health has a testing program with a few Birmingham City schools so that kids can be tested regularly. One of the big challenge with children that we've always had throughout the pandemic, and this is true for other viruses too, sometimes children are less likely to exhibit symptoms. Their immune system is very different than ours in the way that it responds. So what can happen is kids can be asymptomatic carriers and take it home to their adults who are more likely to develop a severe reaction to the virus, a hospitalization. So that's one of the reasons schools have always been a place of interest. It's just that schools have a lot on their plate. So adding the testing and some of those things can be challenging in certain settings, but we are starting to collect that data now, and we'll be able to look with Omicron to see if the mask recommendations, the places that were adhering to masking guidelines versus those that weren't, how spread differed, but that'll still take about 6 months to get those data.
I have one more question about getting the booster after you've been infected. I know initially there was the advice was if you're sick, wait however many days before you get the vaccine. Is there any recommendations on someone who's been infected, how long they need to wait to get the booster after that?
I have not seen an update to the CDC's guidelines. They originally started at 90 days. They moved it down to 30 days, and I haven't seen if they've updated it since then, how long you should wait. I'm not sure, Dr. Dion, if you've seen any updates.
I did see some new wording where they said that someone with natural infection can consider themselves protected for 90 days. So I didn't see it specifically around the booster, but I think they are recognizing, I mean, we all know that natural infection does give you some protection. It's not that it doesn't give you any. We think it's inferior to the protection that you get from the vaccine. But there are studies looking at this. It's a complicated area. I'm telling people if they've had an infection, PCR confirmed infection, that their antibody levels should be high for a period of time. After 3 months, we don't know how high those levels will stay.
Okay, and just forgive me for taking a moment here. I'm just looking through some more questions. I know initially with COVID-19, I think that the CDC was saying if you have protection, in most cases, the natural immune protection for the 90 days, kind of like what you just mentioned. People are asking if there's any evidence or any data on Omicron. At this point, maybe that how long you have protection from Omicron at this point. From getting
Not at all.
Okay.
We have zero data, and it's one of the things that is a little kind of makes me take a pause. An infection that can move this rapid and be this mild, we would expect less immunity. It means your body didn't have to fight as hard, so it doesn't have to keep its defenses high. But again, that's just speculation based on what might happen. But we don't know. It'll take 3 to 4 months to have really good studies looking at antibody levels following Omicron.
And remember, the first Omicron case in South Africa was November 9th. So we're just now 2 months into this variant. We haven't had enough time to know what happens after that 2 months yet. It's too new.
That's kind of hard to, I mean, when you sit and think about that for a second, November 9th to where we are now.
Yeah, it's just a couple months.
One thing I did we were talking about this earlier and I forgot to bring this up, but I know we're starting to see more testing sites, and one of the testing sites at the Hoover Met is a saliva-based test. So can you talk about how that works? And yesterday we were hearing some people were having to wait or possibly being turned away because they had just had a drink or had just eaten or something. Can you talk about how the saliva test works and what you need to know before you go and get one if you're going to go there?
So I can say, I mean, the performance of the saliva test in some studies is not as good as the nasopharyngeal test, and other studies it's very good. So I think it depends on which lab you're using and which study you're looking at. In general, because these antibodies do coat your mucosal nose and the back of your throat, the spit should have the levels of the antigen or that you're looking for the test. I think the issues I've heard is the amount of saliva that you have to collect is quite a bit. It's not something you can take a small amount and be done. A lot of times you're collecting specimen to fill up a tube about this high, and it may take you 5-7 minutes to get and produce enough to be able to do that. I think the concern about eating or drinking is just that you're not washing out all of those good antigens before you do the test. I actually don't know the specific instructions that they're giving. I think if someone was to wait a period of time after they ate or drank and then did the test, I think it would be fine. There's nothing about food or water that's going to inactivate this virus. For some people who don't want to have a blood test, the saliva test is a nasal swab, the saliva test is a good option, but I tend to still recommend the nasal swab for sites that are doing it.
One other question that we're getting is how long after symptoms start do you need to take a test and then be confident that the test is accurate, like that you'll have a positive? I know that initially that incubation period was like 5 to 7 days after the onset of symptoms. We know it's quicker with Omicron. So I know you've touched on that, but will you go over that for someone who's just joining us?
Yeah, so remember that the test that's the best test is a PCR test, and that's going to pick up very tiny amounts of virus. This virus is at very high levels from before you start symptoms until you are several days into symptoms. Any PCR test during that time is going to be positive, assuming it's done by a reputable lab. When we look at PCR positivity on average, you can detect the virus for 14 to 20 days. So it will be there even after your symptoms are gone. By the end of the time period, we're wondering if it's even live virus. Just because a virus is detected and can be replicated doesn't mean it's actually an infectious virus that will grow on cell culture. The distinction is that a lot of people are using rapid tests now, and the rapid tests have a shorter period where they're positive. The way rapid tests are used is to pick up the people who are the most infectious. So if you think about that period of time where the PCR is positive, 14 days, the period where the rapid test is positive tends to be smaller, 3, 5, 6 days. We still need to do more of these studies to understand what the time period is for Omicron. That means that you may have a rapid test that is negative on the same day that you could have a PCR that's positive, and that's what's confusing for people. There's also some concern about the rapid test having reduced performance with Omicron. Again, studies are mixed, but some studies show that the rapid tests don't detect Omicron as well as it detects Delta and the previous variant. So there's these caveats with testing that no test is perfect. What we do when we look at the test result is look at the patient in front of us. If the patient in front of me has symptoms and a sore throat and they're exhausted and someone else in their house has confirmed COVID and they bring me a negative antigen test, I tell them, I really think that you still have COVID even though your antigen test is negative, and vice versa. If someone has been isolated, hasn't seen a single person, has been double vaccinated and boosted and is not having any symptoms but has a positive PCR, then I start to think, is this a PCR test that makes sense? Is this really a true positive or a false positive? False positive PCRs are rare, but you always take the test in context with what are the symptoms, how is the patient doing, and what's happening in the community in Alabama right now. I hope that helps. Testing is a complicated area.
Our time is winding down now, and I just want to have both of you comment on something that we've heard a lot about, and it got a lot of attention after Dr. Scott Harris said this a couple of weeks ago when we were really starting to see Omicron spread. He said this is the type of variant where almost everyone in our state is going to get it. So sometimes when people hear that, they hear it as a caution to take to take steps to protect their family or to make sure they get the booster or do what they need to do to protect themselves. Other people hear that as, well, if we're all going to get it, what's the point of doing those things? It's inevitable. How should people take that message considering how contagious this virus is? What should people do when they hear everyone is probably going to get it?
You want to go first, Dr. Judd, or you want me to?
It's tricky. It's just a tough question, Morgan. The truth is it's a really, really individual response, as most things in health are. It can't be taken out of context of the individual and what your risk factors are. If you're concerned, if you've got an elderly family member or any family member who might be at risk of high risk of having a severe reaction to the virus, those things are all going to change the way that you behave and how you interpret it. And you're right, each person will interpret that message through whatever filter they want to hear it in. The same thing is true when we have something like hepatitis A, they say, oh, strawberries are being recalled because Hep A is prevalent on strawberries. Some people will say, oh, I don't care. I'm going to rinse my strawberries and eat them anyways. And other people are going to say, great, I never have to eat another strawberry again. It's kind of the natural human behavior that would happen with this. I think the key though for folks is to know that there's no guaranteed way you're going to respond. So yes, it's likely you probably will get infected with Omicron, and there's a great chance that you might not have a reaction, but you don't know that going into it. You have no way of knowing if you're one of those people that's going to have an asymptomatic reaction, or you're one of those people that'll be on a ventilator in 10 days. So it's an individual risk calculation. I think at this point, really his message is more around public health. And we know that the hospital can sustain this particular variant, this particular surge, even if everybody gets it. So I think the comment is more around, can our infrastructure take it? Where 2 years ago, if the same thing would have happened because nobody had immunity, it would have basically, we wouldn't have enough doctors and beds and rooms to care for people. To me, it was more of a statement about public health rather than individual health.
Yeah, I often hear people when they hear that type of a statement have that fatalistic, all the stuff I've been doing, it's been for nothing. But the point is that everything we've been doing has been working. We've been able to keep our schools open in Alabama. Our kids are in school and they're getting a good education. And most of my patients are vaccinated and are protected from dying from this disease. So I guess I would say, don't feel fatalistic about it. It looks like it's going to be a high spike peak and hopefully will come back down again quickly. So if you can do some measures to protect yourself and your loved ones, protect those vulnerable people for the next period of weeks, give us some time to let this come back down, then it will be safer again to go out and go about your business. But all the things we've been doing, all the masking, all the messaging, all the social distancing is not for naught. We're here continuing to talk about this. It would be much worse if we didn't have all those measures that people are still following for the most part today.
So it sounds like then we can end on a positive note. And I know that sounds weird when we're talking about a pandemic and there are people who are still suffering and there are people in the hospital, but people are taking precautions. They are learning from this. Is there anything now that you see that is encouraging you as we are continuing to go through this?
I think you're seeing more people in masks. I've been really encouraged by this Omicron surge. We got very complacent at Thanksgiving and Christmas. I think you could see as you were walking around a general attitude of no masking. People were getting back together again. And as the surge happened, we're starting to see more people masking and talking about it. Schools are starting to mask again. So I think the one positive thing that you really see is that people are understanding that we get to move back and forth with our behavior. And it's really encouraging to see people say, okay, I understand, I can mask right now. Hopefully this is very short.
For me, I think what's exciting is the scientific advances. The fact that we have this incredibly effective mRNA vaccine within a period of a year of having the virus isolated is amazing. And we're talking about having an Omicron specific mRNA vaccine by March. So just this ability to rapidly respond to, as the virus changes, we change our response with our most effective tools is a huge win. And now we're looking at mRNA vaccines for HIV and tuberculosis and malaria. This is going to have major impact on public health going forward. And that's a big win.
Okay. Is there anything else that either of you would like to add that you don't think we covered? I appreciate you really being willing to answer any of the questions that we got, and for all of our viewers for sharing their questions. Is there anything you think that we did not hit on that is important for people to know? Final thoughts.
I think we pretty well covered it.
Me too.
Okay, awesome. Well, I appreciate you guys taking the time to talk with us, especially considering all that's going on. We are grateful for your expertise and this opportunity for our viewers to get a one-on-one with you and to ask these questions. So we appreciate everything you're doing. And I'm doing a long a goodbye because I'm waiting for our web person to go back over there so we can, so that way we're making sure we're signing off. But for our viewers to know, this is all going to be posted so you can go back and watch and look at a lot of the things that we talked about, including testing, knowing about natural immunity and why that's not reliable. Dr. Judd explains that very well. Dr. Dion is telling us what she's seeing in the hospital with patients and how effective treatments are now and how there are options. Going back though and saying that the vaccine is the most effective way to protect yourself from severe illness and hospitalization. And you can see that in the data, looking at who is in the hospital right now, but still taking time to protect those in our family, our friends who are immunocompromised and who are at greatest risk from this variant, from this virus. But as the data comes in, we're getting more information, and you guys are great to be able to share that with us and help us be able to consume that and understand it, because we did not all go to medical school. So we rely on you and your expertise and to help us synthesize it and get it out there for folks.